In 2020, according to the Ministry of Internal Affairs and Communications, Japan's aging rate was 28.7% of the total population. In 2021, the rate was 29.1%. It is by far the highest in the world, far ahead of the second place and below. Italy is in second place at 23.3%, and Portugal is in third place at 22.8%. As mentioned above, Japan is now a super-aging society, and it is important to always keep in mind dangerous vertigo and/or central vertigo caused by the brain in the elderly. In the following sections, I would like to explain concrete cases of dangerous vertigo and/or central vertigo in middle-aged and older cases, especially elderly patients, along with MR findings. The following is a case of cerebellar infarction in an 83-year-old man who at a glance might be diagnosed as vertigo from the ear. This patient came to the hospital as an emergency. His subjective symptom was vertigo when he changed the position of his head, and the nystagmus was the same as that of benign paroxysmal positional vertigo of inner ear origin. The CT scan taken on the day was normal. Since he was old and had wobbling, brain MRI was performed 3 days later and revealed a right cerebellar infarction as shown in the figure, and he was introduced to a general hospital. A head CT cannot detect a fresh infarction. CT alone is insufficient. And no abnormalities in head CT does not mean vertigo caused by the ear. This is an episode of another case at a hospital. I once experienced a case in which an elderly patient admitted to the hospital with only vertigo was diagnosed as Meniere's syndrome caused by the inner ear, because only a head CT scan was taken and the brain was normal. A couple of years later, he had vertigo again and visited my outpatient clinic. A head MRI revealed a relatively large obsolete cerebellar infarction. I guessed that this was probably the cerebellar infarction at the time of the previous vertigo. Please note that CT cannot prove a fresh stroke. It is always advisable to have an MR scan at a later date. Again, a clear brain on CT does not mean that the vertigo is caused by the ear. Please keep this in mind. The frequency of cerebellar infarction is said to be around 10% of all cerebral infarctions. Typical symptoms of cerebellar infarction are as follows. 1. Vertigo. 2. Body ataxia. Shaking of the central axis of the body. 3. Strong vomiting. 4. Tongue tangling, also called dysarthria. Dysarthria do not necessarily appear on the day of the infarction. It may occur later. 5. Occipital pain. The figure shows a head MRI of a case of infarction of the medial branch of the posterior inferior cerebellar artery. When the infarction occurs in the middle of the cerebellum, as in this case, the patient has only vertigo and no other symptoms. Therefore, it is often confused with vertigo caused by the ear, as in the above-mentioned case of another hospital. These two cases are a mother and a daughter who suffered from severe vertigo. The mother had vertigo associated with occipital pain. The occipital pain was suspected to be a brainstem or cerebellar lesion. The mother's head MRI showed a small infarction in the left midbrain. Midbrain infarction can also cause vertigo. Anyway, for vertigo and occipital pain in the elderly, the first thing to consider is central vertigo from the brain, rather than vertigo from the ear. The daughter suddenly got darkness in front of her eyes. So-called blackout when she was standing, and she developed vertigo as soon as she lay down. Blackout can also be caused by cardiac disease, anemia, orthostatic hypotension, and hypoglycemia, though when accompanied by vertigo, temporary ischemia of the occipital lobe is likely. The daughter's head MRI showed a small infarction in the midbrain, which was almost at the same location as the mother's. When a middle-aged patient has vertigo accompanied by darkness in front of the eyes, central vertigo should be suspected first, not ignored. It is important to perform a head MRI and MRA. Even mild dizziness and wobbling may indicate cerebrovascular disease in the elderly, so it is better not to take it too easily. This case is a 67-year-old man who had mild non-rotational vertigo but was found to have a small hemorrhage in the cerebellum. He presented to the outpatient clinic with persistent dizziness that made him feel wobbly. Blood pressure was 200/110, blood glucose 265 at any time, hemoglobin A1c 9.5%, indicating poor control of blood pressure and diabetes. The nystagmus was fixed directional leftward rotatory nystagmus like dizziness from the ear at a glance. The combination of hypertension and diabetes mellitus is said to be a cerebrovascular disease reserve, as mentioned above. The head MRI showed a subacute, small hemorrhage in the left cerebellum that had been present for a little while. In this case, the patient was an elderly patient with both hypertension and diabetes, so he had 3 risk factors. Therefore, even if the patient seemed to have swaying dizziness and did not look like a serious disease at first glance, a head, MRI, and MRA should still be performed. In this case, the cerebellar hemorrhage would have been missed if the symptoms were thought to be atypical Meniere's disease. The following are the textbook symptoms of cerebellar hemorrhage. 1. Severe vertigo. 2. Severe occipital pain. 3. Nausea, severe vomiting. These are the 3. However, as shown in the previous case, these 3 symptoms are not always the same. By the way, it is said that cerebellar hemorrhage accounts for about 10% of all cerebral hemorrhage. Elderly patients need to be careful even with mild dizziness. Even mild dizziness, such as wobbling or lightheadedness, can be a hidden sign of a serious disease such as stroke, cerebral hemorrhage, or brain tumor. It is important to check MR in the elderly instead of just taking medication. The following cases are 2 elderly patients with a seemingly mild dizziness. The first case is an 81-year-old man. He visited the hospital complaining of lightheadedness when he stood up and giddiness afterwards. The head CT scan was normal at that time. However, because of his advanced age, his head MRI, MRA, and neck MRA were requested by our hospital and retaken at another hospital 3 days later. The diffusion-weighted image showed a small infarction in the left thalamus. Diffusion-weighted image can show fresh infarction, and infarction in the thalamus can also cause vertigo in general, so this was found to be the cause. The vertigo itself disappeared with the anti-vertigo medicine. However, if the CT scan of the head had shown no problem and it had been determined that the vertigo was due to the inner ear, the small infarction in the brain would have been missed. The second case is also an 81-year-old man. This patient visited me when I was working at the clinic temporarily. His symptoms were unsteadiness and a wobbly feeling. It seemed to be a mild dizziness, but because of his advanced age, he had a head MRI and MRA performed at a nearby general hospital. His head MRI showed a localized acoustic nerve tumor within the right inner ear canal. A small tumor of this size cannot be detected by head CT. As shown in these 2 cases, head CT alone is not enough because sometimes unexpected lesions are hidden behind what appears to be a mild case of dizziness. This case is an 87-year-old man who had persistent lightheadedness. He had hypertension and a coronary stent inserted. He had a persistent feeling of giddiness and swaying from side to side. He visited the vertigo outpatient clinics of a few university hospitals in Tokyo, including the professor's consultation, but was told that the cause was unknown and no treatment was available. At the time of first visit to our hospital, the subjective feeling of swaying from side to side suggested a lesion in the middle of the cerebellum, and during the outpatient examination, saccadic pursuit eye movement. Stepwise eye movement with index tracking was present. This fact suspected a lesion in the cerebellum or brainstem. Nystagmus test using an infrared CCD camera showed positional rebound nystagmus. This finding is mainly suggestive of cerebellar lesions. In addition, since he had 3 risk factors, old age, hypertension, and heart disease, he was ordered to a general hospital to have a head MRI, MRA, and neck, MRA. In particular, the head MRI showed 3 microhemorrhages in the cerebellum clearly on SWI. Right figure, called susceptibility weighted image, although only one was barely identified on T2 star. Left figure, an imaging method that reveals microhemorrhages. Susceptibility weighted image is an imaging method developed in the Netherlands that can distinguish microhemorrhages more clearly than T2 star, and has already been broadcasted for the general public on the BS program, Takeshi's Home Medicine, in 2021. However, aside from radiology, it appears to be still not widely known. The MRI imaging method alone that is currently used in many medical institutions is not enough to solve the problem as shown in this case. So, please be careful when you take a head MRI. In this case, there was a microhemorrhage in the vicinity of the dentate nucleus of the cerebellum. It is already known that lesions around the dentate nucleus of the cerebellum can cause floating fluffy dizziness. Since a cerebellar lesion was suspected at the time of the initial examination, It was determined that the responsible lesion was in the vicinity of the dentate nucleus of the cerebellum. Treatment was started with circulation-improving medicine. In this section, I have explained dangerous vertigo and central vertigo with concrete cases. In the next section, I will disclose some of the most common central vertigo cases, such as vertebrobasilar insufficiency and central paroxysmal positional vertigo.